vector that the electricity moves. So I just want to, this basic thing that I think we all need to understand is that when the electricity of the heart moves towards the lead, it's going to be a positive deflection. And when it moves away from the lead, it's going to be a negative deflection. Okay, that's all I want to say, that we need to understand that when the electricity, overall electricity is moving towards the lead, it's a positive deflection on the ECG, and when it moves away, it's a negative deflection. Okay, so for example, if you have the vector of the electrical activity of the heart moving towards the apex, and where is the apex? The apex is at V5 and V6. You will get a positive deflection in the QRS, right? I think we all know that. Whereas if you have the lead at V1 position in the right parasternal, upper parasternal area, then the deflection of the QRS will be negative because the overall direction of the heart, the electricity of the heart, is moving away from V1. Okay, and then we know where leads 2, 3, and AVF are. 2 is the lower left, 3 is the lower right, and then AVF is directly downwards. So if the QRS is positive in 2, 3, and AVF, this means that the electricity is running downwards from the top of the heart to the bottom of the heart, and that is what's supposed to be normal. Just an example, if you have a patient with ventricular tachycardia or VT, and the electricity comes from the apex of the heart, then you will see that these spikes will be negative in their deflection because the electricity will be moving from the apex upwards, and therefore the deflection in these 3 leads will be negative, which is what we also call a superior axis. Okay, so it's kind of just to have an understanding that when the electricity is moving towards the lead, it will be positive. When it moves away from the lead, it will be negative. Okay. We all know the basic components of the ECG. There is the P wave. The P wave basically represents atrial polarization, and this means the P wave happens when the electricity moves from the sinoatrial node down through the fibers of the atrium, and then before it reaches the atrioventricular node. So that's the P wave, okay, where the electricity is moving in the atrium. And then the PR interval, it's basically the duration of the atrioventricular conduction. This is when electricity slows down in the atrioventricular node and goes through that atrioventricular node. And then the QRS complex, the Q, the R, and the S, this basically is ventricular depolarization, where the electricity goes through the His bundle, through the bundle branches, and then through the Purkinje fibers. And then the ST segment here, the S, the T, is when there is ventricular repolarization, and then sometimes you get a late repolarization, the U wave. Okay? So this is important for us to understand as we try and understand some of the patterns we see on the ECG. A little bit about left bundle and right bundle, because this is another important thing that we need to know. So we can memorize ECGs, we can have some pattern recognition. Once you see enough ECGs, you will know straight away when you look at the ECG what it is. Some of us are not as used to looking at ECGs so often, and so there are some principles. So for example, one principle is that when the electricity moves towards the lead, it's going to be positive, right? Another principle is to be able to determine whether it is a left bundle branch block or a right bundle branch block pattern. Okay, and this left bundle, we know there is an anterior fascicle and a posterior fascicle, and therefore if the whole left bundle is blocked, you will get this pattern. Okay, and so we always use this method of trying to remember left and right bundle. Left, if you look at William, the middle of William is 2 L's, so there's a left bundle. And so the first alphabet of William is W, and the last alphabet is M. So in a left bundle branch block, you will get a W kind of pattern in V1. Okay, well, it's not exactly W, but you know, it's more of a downward S wave. So a W pattern in V1 and an M pattern in V6. So it's like a RSR pattern in V6. So this is a left bundle branch pattern, and it's important to recognize this pattern because you use this to localize where the electricity is coming from. So for example, if you have a ventricular tachycardia that is coming from the right ventricle, you will get a left bundle branch block pattern because it's as if there is a left bundle branch block, although there is no left bundle branch block, but because the electricity is coming from the right of the heart, you get a apparent left bundle branch block pattern. Okay. And the right bundle branch block pattern, we use the term marrow because it is right bundle branch. So the middle two alphabets of marrow is R, right bundle branch. And therefore, in marrow, the V1 has an M pattern or RSR pattern, and the V6 has kind of a W pattern or a deep and slurred S pattern. Okay, so we use William to remember left bundle branch block and marrow to remember right bundle branch block. And I think a lot of you who are senior doctors here, you will know this already, but maybe for the medical students, this is a good way to remember the pattern so that you can recognize this right bundle branch block pattern. So again, for example, if you have a ventricular tachycardia that is coming from the left ventricle, electricity is shooting away from the left ventricle, you will get a right bundle branch block pattern because it's as if the right bundle is blocked. The electricity starts from the left ventricle. Okay? So that helps you to localize where this electricity of the heart is coming from. Another useful, information when you know about right and left bundle branch block is to know where ventricular ectopics are coming from. Okay, so most of us have heard of what we call premature atrial contractions and premature ventricular contractions. In short, we call it PACs or PVCs. All right, I'm not sure whether this is the same terms used in Myanmar, but over here, most people will know when you say PACs and PVCs, okay? So PACs basically mean extra electricity that comes from the top of the heart. That means the atrium, either the right atrium or the left atrium. This is difficult to tell whether it's the right or left atrium that is coming out with this electricity. Essentially, when you see a premature atrial contraction, the QRS complex remains the same because the QRS complex represents the conduction through the septum, and therefore if the electricity starts from the atrium, the extra or abnormal or ectopic electricity starts from the atrium, it will still go down the His bundle and the bundle branches in the same way as a normal sinus node P wave, and therefore the QRS remains narrow and the same. So that's a premature atrial contraction. Usually there is a compensatory pause before the next P wave comes about. Okay, and that compensatory pause will give more time for the heart to fill with blood, and therefore the patients will come to you saying, "Doctor, I feel like my heart jumped, or my heart is kind of jumping out of my mouth, or I feel like I missed the beat." So sometimes they feel like they missed the beat because of this compensatory pause, and sometimes they feel that the heart jumped because this beat here, the normal beat after the compensatory pause, usually has a greater stroke volume, a greater volume of blood that is pumped up because there is a longer diastolic time for it to fill up with blood. Okay. Similarly, you can have an extra electrical activity from the ventricle, and therefore you get what we call a premature ventricular contraction. Usually, you will see a broad QRS that is different from the usual QRS, and that tells us that the electricity starts from the ventricles. Occasionally, you can still have electricity that starts from the atrium, a premature atrial contraction, but as it conducts down the His bundle, you get a bundle branch block, and therefore you can still get a broad QRS complex like this. But usually when you see a broad QRS complex, it is a premature ventricular contraction. Now, then you've got to go one step further. When you see a premature ventricular contraction, you have to tell whether this premature ventricular contraction comes from the right ventricle or the left ventricle. And that's why earlier when I talk about recognizing the right bundle branch block and the left bundle branch block pattern, it helps us, because if the ventricular contraction, the PVC, is a right bundle branch block pattern, then you know that this PVC is coming from the left atrium. And if the PVC has a left bundle branch block pattern, then you know that the PVC is coming from the right ventricle. This is important because when we see PVCs, we need to know when we need to be concerned. Okay, when is it that the PVC is important? When is it that the PVC could potentially be something that is life-threatening versus a PVC that is benign? Okay, and so when you look at the PVC, if possible, if you catch it the right leads on the 12-lead ECG, you want to be able to tell whether this PVC comes from the left ventricle or right ventricle. And number two is you get concerned about premature ventricular contractions when you have a non-sustained ventricular tachycardia. A non-sustained ventricular tachycardia is defined as 3 consecutive PVCs or more. So this is an isolated PVC. This one is what we call a interpolated PVC because there is no compensatory pause. This is the more common type of PVC with a compensatory pause. This one has no compensatory pause, so we call it the interpolated PVC. Does it matter? Not really, it doesn't matter. But this one, usually the patient will not feel. This one, the patient can feel either a misbeat or a strong beat after that. Okay. This is what we call a couplet, a PVC couplet. That means 2 together. And somehow when it's a couplet, it's also not dangerous. But when you see a row of PVCs, 3 or more PVCs together consecutively, then that becomes ventricular tachycardia. And you know ventricular tachycardia is potentially something which is dangerous. Earlier, we talked about localizing where the PVC comes from. So you can see this is the PVC here in V1, V2, and V3, and V4, V5, and V6. And if you remember what I said just now, the William pattern, the W in V1 and the M in V6, this is a left bundle branch block pattern of the premature ventricular complex. And if it's a left bundle branch block pattern, it is left bundle branch block pattern, it means that this is from the right ventricle. Okay. And then you look at lead 2, 3, and AVF. Now we talk about when the direction is positive, means the electricity is moving towards the lead. So if this PVC is positive in these 3 leads, it means that the PVC is moving downwards towards those 3 leads, towards 2, 3, and AVF. That means the origin of the PVC is from the top of the right ventricle. So that's what we call a right ventricular outflow tract premature ventricular complex. So it's a RVOT type of PVC, which is usually benign, okay, and usually something that the patient is genetically predisposed to, and typically it can come on and off during certain times of stress or not enough sleep or too much caffeine, and typically it's not dangerous, although it can still cause ventricular tachycardia, and sometimes we need to treat these PVCs, but most of the time, these kind of PVCs are benign. So when you are able to tell where the PVCs are coming from, then you will be able to be a little bit less scared of these PVCs. Okay. I know there are some questions. I will try and address these questions later on. Okay. Moving over to ST elevations. Okay, ST elevations on the ECG. I think everybody, when they see this ECG, you know the diagnosis. Okay, there is like a tombstone, we call it the tombstone ST elevation, V2, V1, V3, V4, everywhere. from V1 to V6. Okay, so this tombstone ST elevation is basically an acute anterior ST elevation myocardial infarction, or in short, we call it a STEMI. Okay, and you know this is a heart attack. This means that there is an occluded blood vessel. Okay, and if occasionally you see reciprocal ST depression in these leads here, but this patient actually has some junctional rhythm or idioventricular rhythm that came out here, and therefore this is not sinus rhythm, but as the ECG goes along, it goes back into sinus rhythm over here. Okay, so this is an anterior ST elevation myocardial infarction. And the most important thing to remember when you see an ST elevation is that time is hard. Okay, and when you see a ST elevation, it tells you that there is an 100% occluded blood vessel. Okay, sometimes there are no ST elevation, but the vessel can still be 100% occluded. But typically, when you see a ST elevation, you know that there is 100% occluded coronary artery, and therefore it is imperative or important that you unblock this artery as soon as possible, ideally with emergency angioplasty and stenting. But I know that in some areas you cannot get angioplasty and stenting, so you give fibrinolysis. But the earlier you can restore flow in this coronary artery, the better it is for the patient. We all know this slide, that the longer the time the patient has an occluded artery, the higher the mortality. Okay, so every minute counts, time is hard. In that particular patient, he had what we call a widowmaker, or a 100% occluded left main stem artery. This is the catheter, the angioplasty catheter that we put in when we do a coronary angiogram, and we inject contrast into the coronary arteries. But as you see, with the contrast, it just sticks inside this stump here, and a little bit of contrast you see in the aorta, but no coronary artery. Okay, and after stenting the left main into the left anterior descending artery, you see the coronary artery come out. This particular patient was a sailor who unfortunately the employer of the ship, I'm not sure why, cancelled the heli evacuation, and it took him 24 hours before he reached Singapore. We rushed him to the angiogram room and unblocked the artery. He survived actually for about 2 months, but unfortunately, after a lot of struggle, intra-balloon aortic pump, intra-aortic balloon pump, ECMO or extracorporeal membrane oxygenation, in the end, he was too ill. He was flown back safely to his home country, but unfortunately he passed away in his home country. So it is important that we unblock these arteries as soon as we can. This is another ECG. It's a 40-year-old male presenting with chest pain, palpitations, and dizziness. And we all can see here, again, there is ST elevation in leads 2, there is ST elevation in leads 3 and AVF, and then there's ST depression in AVL and lead 1. Okay, so this ST elevation, it means that there is 100% occluded coronary artery. In the inferior leads, it means an inferior STEMI, and that's either a coronary artery in the occluded right coronary artery or an occluded left circumflex artery. This ST depression in lead 1 and lead AVL is called the reciprocal change. And this reciprocal change is very important. Okay? Reciprocal change tells you that the patient has ongoing ischemia. That means there is still ongoing damage to the heart muscle. When you don't see reciprocal change, sometimes it means that the infarction or the myocardial infarction is complete, and the myocardium is dead already. Whatever is dead, and there is no ongoing ischemia. Even when you see Q waves, like this patient, you have Q waves. Q waves do not mean that the infarction has completed. Q waves can happen quite early in the infarction. When there is no reciprocal change and when there is no more chest pain, then you know that the myocardial infarction is completed. Therefore, you don't have to rush the patient to the cath lab. But if there is ST elevation, the patient has pain and there's reciprocal change, then you should rush the patient to the cath lab or give the patient fibrinolytic therapy to unblock the artery. Okay. Now the question is, which vessel is occluded? Is it the right coronary artery or left coronary artery, left circumflex artery that is occluded? Can you tell from the ECG? One way is to look at lead 3 and lead AVF. Generally speaking, if lead 3 is higher than lead AVF2, the ST elevation in lead 3 is higher than lead 2, generally speaking, it is the right coronary artery or dominant left circumflex artery. If the lead 2 is higher than the lead 3, it could be a left circumflex artery. The other way to find out whether it's a right coronary artery occlusion or a left coronary artery occlusion is to do a right-sided ECG. Okay, so when you see an inferior ST elevation or in 3 AVF, you place the V4, V5, and V6 leads onto the right side of the chest. And if you see ST elevation in V4, even 1 millimeter ST elevation in V4 or V5 or V6, then that's a right ventricular infarction. When you see a right ventricular infarction, invariably it is a RCA occlusion. And when you see a right ventricular infarction, you have to be careful not to give the patients nitrates, which dilate the venous return, which reduces venous return to the heart, because nitrates can drop the blood pressure of the patient quite a lot. Okay? So when you see a RV infarction, try not to give nitrates. That means don't give GTN or or nitro patch or nitro spray to the patient. A real patient with a 50-year-old. So most of these ECGs are my patients that I've seen before. This is a 50-year-old guy with a chest pain for 2 hours prior to presentation. Okay. So you look at the ECG, the A&E doctor saw this ECG and said it's a normal ECG. But if you look carefully at this ECG, there are a few clues that you shouldn't send this patient home. Okay. So number one, there is very subtle ST sagging in V6 and a little bit in V5. It's very subtle. You got to kind of imagine it a little bit, but you can see the ST segment is about 0.5 to 1 millimeter down. Okay. And number two, don't miss the T inversions in AVL as well as lead 1. Okay. So the T inversions in lead 1 and AVL is suggestive of a high lateral infarction. A high lateral infarction is usually due to an obstructed diagonal artery. Okay, a diagonal artery is a branch from the left anterior descending artery. When you have a diagonal artery infarction, although it's a branch, never take it too lightly, because it may mean that the patient had a transient occlusion of the left anterior descending, which is a very important artery. That means if the patient had a transient occlusion of the LAD, it could have some clots that went down to the diagonal and caused the diagonal to block up. And when the diagonal branch blocks up, you will get sometimes ST elevation in leads 1 and AVL. But for this patient, the infarction has completed, and therefore you get this kind of T inversion in lead 1 and AVL. And if you do the troponin T or troponin I for this patient, it will be abnormal. Okay? So don't miss the subtle sign. Occasionally, you can have a patient coming to you with severe chest pain, they're sweating away, looks like the patient is having a heart attack, but the ECG is totally normal. Okay? Don't be fooled, because sometimes the ECG can be totally normal in a patient with a left circumflex occlusion. If the left circumflex is not very big and the left circumflex is occluded, the patient can have severe chest pain and you have nothing on the ECG. Okay. So sometimes, even if the ECG is normal and the pain is very suggestive, especially if you've done a troponin T and troponin T is raised, you need to bring the patient to the angiogram room sooner rather than later, to to unblock an occluded artery. Okay, so don't forget, circumflex artery occlusions sometimes can give you a normal ECG. This is a patient, 45-year-old with chest pain for 2 days, and now he has no more pain. You can see very obvious T inversions, very deep symmetrical T inversions in V2, V3, V4, in 1 in AVL. Okay, so this means that the patient had an infarction. This is what we call a non-ST elevation myocardial infarction, and is almost definitely from the left anterior descending artery in the proximal part of left anterior descending. Okay, proximal, why? Because you have T inversions in 1 and AVL, and that means the diagonal branch is also involved. The anterior territory is involved, diagonal branch is involved. This is a proximal LAD stenosis, or even a left main stenosis. And this is something that you need to take seriously, because anything in the left main stem or the proximal LAD is life-threatening. This is another patient who comes to the A&E with ongoing chest pain. And what you see here is you see ST depression in lead 2, in leads V2, V3, 4, 5, 6, so diffuse ST depression in all these leads, as well as ST elevation in AVR. When you see diffuse ST depression and ST elevation in AVR, and the patient is still having chest pain, you have to also take this seriously. Okay? This is either due to a severe triple vessel disease with a very, very tight coronary artery, or it could be left main stem stenosis, or it could be severe triple vessel disease with an occluded vessel. Okay, either the circumflex is occluded, one of the RCA branches, the RPD, the right posterior descending, or somewhere along the RCA is occluded, and the patient has underlying severe triple vessel disease, then you get this ST depression diffuse and ST elevation in VR. You may not get any ST elevation even in a 100% occluded artery, but if the patient has ongoing chest pain, again, if you have a cardiac catheterization lab, you need to bring this patient to the cath lab. Moving on to ventricular tachycardia. I think I got this slide in the wrong place, sorry. Let's look at this anyway. So this one, most of us can tell, is a broad complex tachycardia. And how do you tell whether it's a ventricular tachycardia? You look for AV dissociation, atrioventricular dissociation. And what tells us that there is atrioventricular dissociation? There are some clues. Basically, you can see there is P waves that moves in and out of QRS complexes, or you see either capture waves or capture QRSs or fusion QRSs. So this is normal QRS coming out from the white complex tachycardia. You get some normal QRS complexes, and then you get this complex, which is a fusion of the white complex and the narrow complex. This tells you that most likely this is a ventricular tachycardia. Of course, the patient's history, you can also tell. If the patient has ischemic heart disease, the patient is 60 years old, 70 years old, you know that this kind of tachycardia, broad complex tachycardia, is most likely ventricular tachycardia. Okay, we'll come back to this again later on. I think this slide, I put it there to just illustrate when the patient, this particular patient, okay, because we're talking about ST elevation now. This particular patient came with a ventricular tachycardia. He was cardioverted electrically, and then after cardioversion, you see this ECG. Okay, you can see there is ST elevation in V2, and there's a bit of ST elevation in V3, and then there are V2 waves in V2, V2 waves in V3, and there is no reciprocal change. Okay, no reciprocal change. So in this patient, when they come with ventricular tachycardia, you can tell that the patient had an old myocardial infarction, and most likely the ejection fraction is poor. Okay, and most likely there is a scar in the left ventricle that triggered the ventricular tachycardia. And in this kind of patients, you need to insert an implantable defibrillator. you need to put in an ICD because the ventricular tachycardia will come again and it can kill the patient. Recently, I had a patient who was asymptomatic and he had an ECG like this, and his ejection fraction was only 15 to 20%. He had ischemia proven on fractional flow reserve, so he had a stent. But during the admission for stenting, we noted that he had a lot of non-sustained ventricular tachycardia. He was totally asymptomatic, but I decided to put in the ICD for him, even though I just stented him. And thankfully, about a month later, he actually got shocked in his sleep, and he had runs of ventricular tachycardia that was very fast. And if we didn't put in the ICD, he would have died in his sleep. This is a 20-year-old, in Singapore, we have national service, so a 20-year-old national serviceman presents with fever, flu, dyspnea, and chest pain, okay? And one episode of seizure during his in-camp training. So this is his ECG. This is another example of ST elevation. You see the ST elevation in V2, 3 AVF, and the ST elevation in V3, V4, V5, and V6. 20-year-old guy, I don't think most of us will not think of a heart attack or a myocardial infarction in a 20-year-old guy. With fever and chest pain, most of us will know that this is acute pericarditis. Okay? So acute pericarditis, you get diffuse ST elevation, sometimes not so diffuse. If the pericarditis is localized, for example, to the inferior wall, you get inferior ST elevation. If it is localized to the lateral wall, you may get lateral leads like 1 AVL, V5, V6. These are the lateral leads. You may get ST elevation only in these leads. But predominantly, most of the time when you get pericarditis, it's global pericarditis. So you get ST elevation in all the leads in the inferior as well as the anterolateral leads. And you get what we call PR depression. Okay, so the PR interval is depressed lower than what would you expect. So in acute pericarditis, you got to give patients pain relief, usually high dose aspirin, like aspirin 300 milligrams 3 times a day, ibuprofen, Simplex or naproxen to reduce inflammation. And importantly, in acute pericarditis, you have to look for myocarditis. So you should run a troponin T for the patient to look for whether myocardium is involved. When you have myocarditis, they can be very sick. Okay? And now in the era of COVID-19, myocarditis and pericarditis is important. If you have COVID-19, you are at risk of myocarditis and pericarditis. If you have the COVID-19 mRNA vaccines, you are at risk of myocarditis and pericarditis. So this is something that you need to know. And you know, really, some of the sickest patients in cardiology are the myocarditis patients. You have to pick that up when you see this kind of ECG. This is another example of ST elevation. You get ST elevation that is very tall, thin, and peaked. This is what we call symmetrically ST elevation. Very tall T waves here. And this is an 80-year-old with who is taking Valsartan, which is an angiotensin receptor blocker, Spironolactone, as well as on Lasix and Potassium. So obviously, most of us, when we see this ECG, you will know that you need to check the patient's potassium, okay, because this is hyperkalemia until proven otherwise. A 6-year-old gentleman presenting with shortness of breath, exertional dyspnea, one episode of syncope, and clinically he is in crank heart failure. And when you do an angiogram, he has normal coronary. So what is this ECG? It looks like sinus tachycardia, but look at the lead 3 and lead AVF. You will see that there is this sawtooth appearance in lead 3 and AVF. You know that this heart rate is very, very fast. If you look at the leads, you can't really see, you can see the P waves here and here. But you can't really see that there is another P wave hidden in the QRS complex. Okay, there is another P wave hidden in the QRS complex, and this is actually atrial flutter This patient had atrial flutter for a long time, and when you have atrial flutter for a long time and you are tachycardic for a long time, this can cause tachycardia-mediated cardiomyopathy. Ejection fraction of the patient will drop. The patient can come with an EF of 20%, 25%, and you need to convert this atrial flutter and control the heart rate so that the cardiomyopathy can improve. And this is a good kind of cardiomyopathy because if you convert the atrial flutter with electrical cardioversion and eventually maybe a radiofrequency ablation, the patient's ejection fraction can normalize to totally normal as long as you control the heart rate. So don't miss the subtle atrial flutter because many people will diagnose this as sinus tachycardia, but it is not sinus tachycardia, it's atrial flutter. And atrial flutter is notoriously difficult to control with medication. Even if you give a lot of medication, you may slow it down a bit, but it's very hard to get good heart rate control. So you have to convert this either with IV amiodarone or the easy way is to use electrical cardioversion. So some of the atrial arrhythmias that we need to be aware of are atrial fibrillation. I'm not going to talk too much about atrial fibrillation because most of us, when we see atrial fibrillation, we can recognize it. It is a haphazard baseline. There is no real P waves that you see, and the QRS complexes are irregular. That's atrial fibrillation. When you have a sawtooth appearance, that's atrial flutter. Sometimes atrial flutter will come with a 2:1 AV block so that the heart rate will be 150 beats per minute usually. Sometimes it will come with a 4:1 AV block and the heart rate will be 75 beats per minute. Sometimes it can come with a variable block and it looks like atrial fibrillation. Okay. Can also have accelerated functional rhythm, especially in patients, for example, in toxicity. You can have junctional rhythm. Junctional rhythm, you see the QRS complex is narrow, and then you sometimes can see a retrograde P wave here. If you see a retrograde P wave here, it's because the P wave is actually triggered by the junctional rhythm. Okay, and therefore, and if it is higher, if the junctional rhythm is higher than 60 beats per minute, then that's called an accelerated junctional rhythm. If the rhythm is less than 60 beats per minute, then it's just called junctional rhythm. Okay, these are some of the atrial rhythms that you need to recognize. This is another irregular atrial rhythm that frequently is mistaken as atrial fibrillation. Okay, so a lot of physicians, when you see this kind of irregular QRS complexes, you think that this is atrial fibrillation. If you look at it, there are P waves that you see. You can see a P wave here, a P wave here, a P wave here, a P wave here. This is what we call a multifocal atrial tachycardia. And what is the definition of multifocal atrial tachycardia? You must have 3 or more atrial foci. That means there must be 3 or more pattern of P wave. So if you can look at this P wave, is different from this P wave. This and this is probably the same type of P wave. This one and this one is also a little bit different. Why is it different? Because the PR interval is different from this PR interval. So you already have 1, 2, and 3 different P waves. This P wave is in, or maybe there's no P wave here, it's a junctional rhythm here. And so if you have 3 or more different type of P waves, you call that multifocal atrial tachycardia. Why is it important to differentiate multifocal atrial tachycardia from atrial flutter or atrial fibrillation? It's because multifocal atrial tachycardia, or we call it MAT, they are not at risk of thromboembolism. They're not at risk in getting stroke. You don't put them on oral anticoagulation. If you see atrial fibrillation or atrial flutter, then you need to put them on oral anticoagulation. They fulfill the CHEST-VAS score of 2 or more. We won't go much into that, but if you fulfill the criteria for oral anticoagulation, you need to put them on anticoagulation to prevent strokes and thromboembolism. But if you see a MAT or multifocal atrial tachycardia, then you don't put them on anticoagulation. And typically when you see a MAT, you have to think about lung disease. Does the patient have chronic lung disease? The patient have pulmonary embolism or something that increases the pressures in the lung. For example, even a patient with pulmonary hypertension from an atrial septal defect can have MAT. Is there electrolyte disturbance, digoxin toxicity, hypoxia, etc.? Okay. We have this 80-year-old. So next we move on to this 80-year-old male, no past medical history, and presented with dizziness as well as palpitation. So what do we see in this telemetry reading? So this is a telemetry strip. You see these spikes here, which are atrial flutter waves. Okay, so these are atrial flutter waves. And then you see a long straight line here, which is basically a short pause, a long pause, sorry, it's like a short asystole. So long pause, and then you see the flutter waves. So what is this? This is what we call tachybrady syndrome, tachycardia-bradycardia syndrome. Okay, so in patients with atrial flutter and atrial fibrillation, the whole reason why they have atrial flutter and atrial fibrillation is because their atrium is not normal. So if their atrium is not normal, their sinus node may also be affected. Okay, so if the sinus node is affected, the atrium is not normal, they get AF, they also get a sick sinus. So it is not uncommon that in elderly patients with AF, you will get sometimes fast, sometimes slow. And so treatment of these patients will require you to put in a pacemaker to fix the slow problem. So if you put a pacemaker in, then you fix these sinus pauses, then you can give them rate slowing agents like a beta blocker or a calcium channel blocker to slow down the heart to fix the atrial fibrillation, atrial flutter problem. If you don't put in a pacemaker, you can't give them rate slowing agents, and then they become very symptomatic. They have sometimes palpitations, sometimes dizziness. In severe cases, they may faint and injure themselves. When you have atrial fibrillation, pauses happen when atrial fibrillation converts to sinus rhythm, but sometimes pauses can happen within atrial fibrillation as well. Generally speaking, if the pauses are less than 5 seconds, most of the time the patients don't feel it. They may or may not need a pacemaker. If the patients are symptomatic and the pauses are more than 5 seconds, then definitely they will need a pacemaker. This is a ECG of an 84-year-old lady with a history of hypertension, and the patient presents with recurrent thinking spells, recurrent syncope. So what do you see in this ECG? Number one, remember marrow, there's an M in V1 and W in V6. So a marrow pattern is a right bundle branch pattern. Okay, so this patient has a right bundle branch pattern in the QRS complex. The other thing you notice is it's very slow. Okay, the QRS between one to the other is very slow. It's definitely less than 60 beats per minute. And then you can see the P waves here, P wave 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 here. Somewhere here there's a P wave, here there's a P wave, and somewhere hidden is a P wave. Okay, so the P wave rate is about 75 beats per minute. The QRS rate is maybe about 40 beats per minute. And so this is atrioventricular dissociation or complete heart block. Okay, so this is a complete heart block, and this is a high risk complete heart block because the QRS is broadened. It is a right bundle branch block pattern. It means that there is no connection between the electricity in the atrium and the ventricle, and the ventricle is beating on its own. It's coming out electricity on its own, and the electricity is coming out from where? When you see a right bundle branch block pattern, it means that the electricity is coming out from somewhere in the left ventricle, and you see here it's moving towards the inferior leads, means it's moving somewhere from the top part of the left ventricle. So it's coming from the left ventricle, part of the left ventricle, and because it is not coming from the His bundle, this is an unstable rhythm, and the patient should be put on a temporary pacing wire because this patient can deteriorate and become hypotensive and go into heart failure. Okay, so this is complete heart block. You need to recognize this, and you need to know that this is a high risk complete heart block. For atrioventricular blocks, there are various types, various degrees of atrioventricular block. From the commonest and the most benign atrioventricular block is the first degree AV block. First degree AV block is when the P wave and the QRS complex is further away. There is a prolonged PR interval, which is more than 200 milliseconds. Okay, more than 200 milliseconds is first degree AV block. First degree AV block is because of a high vagal tone. That means the vagus nerve tone is very strong. It is seen in athletes, it's seen in young patients, sometimes in elderly patients. It is because of disease in the AV node, but most of the time, first degree AV block is benign. It is because of a high vagal tone. In young patients with first degree block, most of the time we don't need to do anything. We don't need to be too alarmed. Then there is the second degree AV block, type 1, what we call the Wenckebach AV block. Second degree AV block is also because of a high vagal tone, high vagus nerve tone, and it is in the first part of the AV node where the electricity slows down. So what you see is that the PR interval progressively prolongs. So this is a PR interval. It progressively prolongs until it gets totally blocked for 1 beat, and then the next PR interval comes back. It's back to the shorter PR interval. Now, what is the easiest way to tell that this is Wenckebach? It's important to tell that this is Wenckebach because Wenckebach is not so dangerous and we are not so alarmed. So the easiest way to look at Wenckebach is to look at the missed beat. So you see a P wave here and no QRS complex. So when you see the P wave without the QRS complex, that means the blocked P wave, look at the PR interval before and you look at the PR interval after. If the PR interval before and after is different, then this is Wenckebach. Okay, if the PR interval is longer before and the PR interval after is shorter, this is Wenckebach. The other way to tell Wenckebach is that the QRS is not regular. You look at the QRS is not regular. Okay, there is some variability in the RR interval. That's another sign that this is Wenckebach. If you look at type 2 second degree AV block, which is the more dangerous type, you will see, look at the P wave here is blocked. There is no conduction down to cause a QRS complex. You look at the PR interval before, and you look at the PR interval after, it's exactly the same. So the PR interval after and before is the same. This is a type 2 AV block. Type 2 AV block is usually or almost always due to disease in the AV node. There is some problem with the heart, either ischemia or hypertrophy or degeneration. So you have to take this seriously. Okay. And then, of course, we've talked about the third degree AV block, where the QRS is doing its own thing and the P waves is doing its own thing. The P wave is dissociated from the QRS, and in third degree AV block, the QRS RR interval is regular. Okay, it's regular. So there is regular QRS, very slow, and then there is regular P waves, but they have nothing to do with each other. Okay, so in this kind of patients, in degree AV block, many times in second degree type 2 AV block, you need to put in a pacemaker. I have a lot more slides, but we'll try and just finish this one. Now, that particular patient, if you remember this patient, the 84-year-old lady, very slow, we plan to bring her to ICU, and then we are getting the team back, the radiology lab, to put in a temporary pacing wire. But while we wait for the radiology and the patient is on the telemetry, this is what happened. Okay, so bradycardia can cause, sometimes lead to ventricular tachycardia. And if you look at this ventricular tachycardia, you see a sinusoidal pattern. Okay, this is not a monomorphic VT, but what we call a polymorphic VT. The QRS changes, and it changes to a smaller QRS or a shorter QRS to a longer QRS. And this is Torsades-de-Pointes. And this is what we call polymorphic VT, and it can be due to bradycardia. Severe bradycardia can lead to torsades and the patient can collapse and die. Okay, so for this kind of patients, we need to immediately shock them out of torsades. We can give them IV magnesium, and then we need to clean the pacing wire to pace the patient. Once you pace the patient, if the torsades is because of bradycardia, then the torsades will not come back again. Okay, so torsades de points is basically polymorphic ventricular tachycardia. It is usually due to long QT intervals and can be due to very severe bradycardia. And usually the ventricular rate is very fast to shock the patient out of this with magnesium as well as pace the patient. Okay, I think we have to stop here. I have many more slides on the ECG, and maybe if you would give me the honor of doing another talk with you, we will continue another day. Maybe we take some of the Q&A. Is that okay?